Good morning. Today we'll be talking about cancer because this month is the Childhood Cancer Awareness Month. We're going to be talking about celebrating the victories of children living with cancer. Good morning, Professor Temiye. Good morning, Dr. Nwobbi. It's a pleasure to have you, both of you, here with us today.
Well, it's a
So,
pleasure being here today.
thank you, thank you. So, if we can start with you, Prof. This is an important month, talking about childhood cancer awareness. And I love the thought of celebrating the victories of the children living with cancer. Can you talk to us about, you have a lot of experience in this area and you're also a specialist in transplantation. Can you talk to us about different childhood cancers? And then can you talk to us specifically about the ones that you are involved in that can require bone marrow or stem cell transplant? But first, just talk to us about cancers in childhood.
Okay, thank you very much. Cancer in childhood, let me first say, it's a rare disease. It's about 4% of all cancer that are recorded anywhere in the world. But one of the things that is common in them is that they are very, very aggressive. If you don't treat on time, within 1 year, most of the children will have been lost to the disease. The commonest cancer we have in Nigeria are blood cancers, which we call leukemia, and we have lymphoma also. So we call them leukemia lymphoma. They affect the nodes, the lymph nodes, and they affect the bone marrow. Those are the commonest cancer we have in Nigeria. Followed by kidney cancer, which we call nephroblastoma. Then Nigeria is one of the places where you have the highest rate of cancer in the eye, which we call retinoblastoma. So if you take these 4 cancers, more than 70% of cancers in Nigeria will have been covered. In those days, they used to talk about bucket lymphoma as being common in Nigeria. Maybe because of improvement in socioeconomic status, it's not as high as what we thought. But blood cancer, lymphoma, nephroblastoma, which is kidney cancer in children, and retinoblastoma, which is eye cancer in children, are the major cancers that we have in Nigerian children. When we're talking about bone marrow transplant and cancer, most cancers can be treated with bone marrow transplant, but usually it is when you fail to get cure from conventional treatment with chemotherapy. That is when we resort to bone marrow transplants to cure them. And the major ones that we use bone marrow transplant to cure is actually the blood cancers and the lymphomas. They're the major ones that we use this disease to cure. By the time we are talking about the so-called solid tumor like nephroblastoma or retinoblastoma to use bone marrow transplant to cure them, the disease must have spread. The child is in stage 4 disease or is resistant to treatment, and commonly, may not get as much results as we get when you use it for blood cancers. Right now in Nigeria, the transplant we are doing, we are just starting, and we are trying to graduate to using bone marrow to cure cancers. Majorly, we are dealing with bone marrow failure and sickle cell disorder. We hope that by the next 1 year or 2, we move to treating blood cancers with bone marrow transplants. I think that is what I need. I can say for that. We need an explanation. I can give it.
Thank you. So can you also talk to us a bit? I know we're not doing it here in Nigeria yet, but a bit about stem cell transplants as treatment for childhood cancers. Is it an option?
Okay, yeah, it's an option. Usually it's an option for
Can you
blood.
explain first what is the differences between stem cell transplant and bone marrow transplant? Don't forget we're talking to lay people here on the radio.
Stem cell transplant and bone marrow transplant is the same thing. We are talking about the same thing. What happened is that in every cell in our body, to rejuvenate, we need the stem cell, the committed stem cell to that particular thing. Like your skin, under your skin, you have some stem cell there, which rejuvenate your skin from time to time. In the bone marrow, we have bone marrow stem cell, which rejuvenate the bone marrow that makes you to produce your blood cells of different types. So it's those stem cells we aim for in the bone marrow. It is because it's easier for us to collect it in bone marrow that we use bone marrow to collect it. In some center, they collect the stem cell because some of them circulate in the peripheral, in the blood, and you can actually collect them from the blood. So what we do is that we collect the bone marrow of the person we want to use as donor. Sometimes maybe the patient in some cancers, if they're not spread to the bone marrow of that person, you can use the bone marrow of that particular patient, collect it, and then process it to remain only the stem cell. The stem cell are the cell that can rejuvenate the bone marrow. If you remove everything, you can still put it back. It will grow back in the bone marrow and form all the cells of the bone marrow. The white cell, the red cell, the platelet. Those are the stem cells. And when we have a particular system we use to identify those stem cells and concentrate them and remove all the mature cells from the cells we collected. So you may find out that we collect about 1,000 mil. By the time we finish processing and remove all the more mature cells, we may have about 500 to 600 mil left to be transferred back to the patient we want to give it to. Usually what we do is that in sickle cell, for example, we prefer to use donors who are matched to the person, that is sibling. Usually your closest relation is your sibling. That's the closest person to you. So we do what we call HLA typing. And if the HLA typing matches in about 4 or 5 loci, then we say the person is fully matched, and that person will use that person. If they are not fully matched, if they are half matched, once they are mismatched, then one of the issues that we have is what we call graft-associated disease. Even in full match, we have some graft-associated disease because it's not exactly full match. The only person that is full match, that there may be no graft-associated disease if you have an identical twin. But if you don't have an identical twin, then definitely there'll be some graft-associated disease or host versus graft disease. What happened is that the cell you transplanted identify the body I'm inside is not my body and start attacking it.
But
and the person that retrieved the blood, the person retrieving the blood, also said, "This is not my cell," and start attacking it.
Yes.
Yeah.
Yes.
You want to ask a question?
Yeah. So before not those. So this what you're talking now about some of the challenges that are in actually providing successful transplants in general. Okay. So this is what you're. So just to clarify to the people who are listening that you're now talking about some of the challenges. Please carry on.
But what happened in cancer cells that sometimes we allow some graft-associated disease to occur because that fight may be useful in eliminating the cancer cell itself.
Oh, okay. That's interesting.
So allowing some graft-associated disease when you are doing cancer transplant is allowed so that it can destroy the cancer cell in that person. So we use drugs to modify this attack and mellow it down so that eventually the body accepts the cells you are giving to the other person. So what is most important in cancer and bone marrow transplant is that you must be able to properly process the bone marrow you collected, ensure that the person you are giving the bone marrow to and the person who is giving it, they are matched to a large extent. If they are fully matched, we're happy. If they are not fully matched, if it is cancer, if the mismatch is not much, then it may be beneficial to the person. But for sickle cell, we prefer them to be fully matched. It's when we don't have that we go for mismatch, yes.
Thank you so much. I think that's very interesting. And I don't know if I should ask you this or if I should ask Dr. Nwobbi, but are there any promising new therapies apart from transplants or innovations in pediatric oncology that give us hope for the future?
Yes, there are. One, what we call the biologics. You see, every cancer cell carries an information that other cells in the body does not have. Now, if you can identify that molecule and you develop an antibody against it, then it can assist you in eliminating the cancer cell and controlling it very fast. Usually when we treat with chemotherapy and we're having issues, if you know the kind of molecule that cell is carrying, then we can use biologic that is targeted that molecule and use it to eliminate that cancer cell faster than it is necessary. However, most of these are expensive. The second one that is coming up now is what we call CAR T cell. CAR, like a car, chimeric antigen receptor T cell. It has been shown that it is because the T cell of the patient tolerated the cancer, because the T cell usually destroy abnormal cells in the body normally. The one that is really the fighter in that case is what we call natural killer cells, which are in our body. They're part of our lymphocytes. If they tolerate the cancer cell will continue to grow. It was so that if you find a T cell that does not tolerate that cancer cell, it will destroy the cancer cell. So right now, the chimeric antigen receptor T cell therapy is being used for starting first with acute myeloid leukemia, which is a form of blood cell leukemia, and it was found to be successful, and it's being expanded now to treat more cancers. However, this treatment is quite expensive. Yeah.
Yes. Oh, thank you. Thank you so much for that information. Dr. Nwobbi.
Yes, please.
If we can just start with you, can you share with us what inspired you to start this very important Children's Cancer Foundation?
Thank you so much. I was working under Prof when we had a child. No, I was in the emergency room actually. And then there was a child that came in, taking history and all that. You know how, you collect the patients. And unfortunately, I was just very wet behind the ears. And I was like, okay, fine, we need to investigate your son for leukemia. And the parents was very upset, And at the end of the day, the child actually had leukemia. My next posting was hematology oncology when I was working on that Prof, and the child was admitted onto the ward under Prof. Temiye, and it was devastating for the family. It was the first child, and they had spent everything they had, sold their television, sold their radio, so it was quite traumatic. And at that time, we had another child that was from Sierra Leone, and that child too, the parents had spent everything they had, and they were on admission and could not leave because they couldn't pay the hospital bill. Going online to look for charities that support childhood cancer, we didn't see any. And speaking with a mentor of mine, I was like, yeah, why don't we just start one and then try to help the same children? Because I had actually gone fundraising, trying to get funds to get these children out of the road to go back home. The first child I spoke about, he was discharged and didn't come back until a day before he passed. So that was actually what inspired the foundation.
Thank you. Thank you very much. Dr. Nwobbi, what you shared was so inspiring. Can you share with us some of your impact stories or milestones that your foundation's achieved so far? How does your foundation help the children access treatment and support services?
Oh, thank you so much, Dr. Pamela, for this question. Chidera is actually one of our success stories. And incidentally, I met her when she was 13. And then to have her limb amputated was not an easy thing, but she agreed. And then last year, we had another child who had the same ailment, osteosarcoma. And because we actually meet every month to interact with children in the ward, we have our survivors come and we all interact. This little girl had the same thing, and she was finding difficult, to agree for the amputation. And then Chidera walks into the ward and she said, Auntie, what is wrong with your leg? And Dera was able to tell her what had happened to her. And incidentally, Dera had actually helped, or rather had come on a counseling course that we give to parents and volunteers to be able to counsel the children and their caregivers in the ward. By the time that I finished talking with her, the girl was very relaxed, had formed a rapport with Dara. And then I think 2-3 weeks later, she had the surgery with all confidence that she was going to leave. And I'm very happy to say that today she's alive and well and is a survivor of childhood cancer. So that is the kind of
that's wonderful.
So and then we have other things that we try to help with. One of the things that I believe help out is having something to look forward to. So we have this art therapy. We organize art workshops for the children, and they come, and they're so happy, looking forward to working with the artists, making beads and other things. So that's one of the things that we do. We also try to, we actually give chemotherapy drugs for any child who needs it and had approached us. The other things that we don't usually do, but we do if there's a need, is something like investigations. We were able to raise 1.4 million naira for a child that's, needed PET scan. I didn't know it was that expensive, And so by the time and that was for children. I hear adults is much more expensive. The parents have spent practically, in fact, they were in debt already. And the doctors needed to have this PET scan done to be able to go forward with the treatment. And the mother was like, okay, let us go home. Whatever happens, happens. And after speaking with the parents and the child, we were able to raise the funds and the child had the PET scan done. So generally, we try to give the free chemotherapy drugs, we give free counseling, and of course, try to create awareness, which is one of our biggest points.
Very, 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 very important. So can you tell, for those who are listening out there, there's somebody in need who wants to reach out to your association. Is there a number that you can give us right now that they could reach out to you on?
Oh, okay, that on WhatsApp and online, 080 33 156 908.
Please repeat.
080 33 156 908.
Thank you so much. If I can then just go over to Chidera. Chidera, how are you? It's wonderful to see you looking so beautiful here today.
Really beautiful.
Thank you, Ma.
Yes, you're so lovely. So we've heard a bit about your story, that from Dr. Nwobbi. But can you just tell us, share with us perhaps not just the story itself, but your emotions along the way and how you feel now and how you're celebrating, because we are here celebrating your victory with you. So can you just share with us just an insight, give us an insight into how you...
Okay, good afternoon, everybody. My name is Chidera. I'm a cancer survivor. I had cancer when I was 13. And it was challenging because I never knew that children do have cancer until when it happened to me. And mine wouldn't have been this bad if we were not delayed or we accepted the fact that children do have cancer, because we didn't have the knowledge, like we were ignorant in that aspect. So that was why mine had to cost me my leg for them to amputate it, because we didn't go to the hospital on time. We went to all this traditional bone setter thinking it was just dislocation. After 6 months, we went to Bagada. From Bagada, we had to go to Igbobi, where they run series of tests, and they found out that I had cancer of the bone. And then it was really difficult affording chemotherapy. Very, very difficult. We are at this stage 1 when my consultant, Dr. Sheido had to connect us to Dr. Nneka Nwobbi, saying that there's a lady that has a foundation and she helps with this chemo. That was how we came in contact with her. And I took chemo for 9 good times, and she provided it, making it less stressful for my family. And what I would say, I was actually brave during my section because I'm a happy girl, and I use that lifestyle to encourage myself, because left for my mom, they wouldn't have amputated my leg. Maybe by now I would have been dead, but I had to make the decision that yes, since I'll be given a second chance to life, it's better that way. And funny enough, it's been 12 years now, or 13 years, and I've been living my life the way I would have lived, or even better, because I had to accept the fact that this is what has happened. And people around me has been encouraging.
That's fantastic.
They have been encouraging. So that's it.
Fantastic. Thank you so much. In fact, I wish this program would not end so soon, but we only have a couple of minutes left on the program, but I'm so happy that we're able to celebrate your victory over cancer, and we thank God for your life. So do you have any words to advise or to give advice to mothers and parents out there who may not be accepting of this kind of condition? Just a couple of words, last words.
Okay. My first advice to parents is they should be learned, like they should acquire knowledge, because I think because my mom was ignorant, that was what cost me my leg. Because if she had the knowledge that children do have cancer, I think it would be a first step for us in tackling the challenges. So I think parents should be open-hearted to learn, to acquire knowledge in different aspects, and they should be conscious about their children. Like every little thing, they should be conscious, not just taking anything for granted. They should be very careful observing their kids, because one of my friend, Oluchi, she's married now, she had cancer of the ovaries, and I think then she was young, maybe 12 years or 10 years, I don't know. But she had cancer of the ovaries, and to her, they thought it was malaria. So I think parents should be open to knowledge, and they should observe their children.
Thank you so much. Dr. Nwobbi, do you have any last words for our listeners?
I think I would go with that. Parents should be more learned, and then the government should help us in creating this awareness. Elsewhere, this month of September, we will have gold things all around the city. Gold lights, gold ribbons, people coming to work with gold ribbons on their shirts and things like that. So we should encourage that so that people can be more aware. The awareness would actually make parents bringing their children in on time, and then possibly, they would achieve cure.
Thank you. Dr. Temiye, Professor Temiye, do you have any last words for our listeners?
Okay, yeah. The last one I have, like that we are hearing now from the survivor, is that patients should present early. Childhood cancer grows very fast. They roar like like they're trying to catch up with the child growth. Delay is dangerous, because while you delay, you cause problem. And sometimes we're lucky with these bone cancers, where they go and massage them, they push it into the blood, and before you know it is in the lungs. It is all over the place. And at that time, there's not much we can do when they come. And sometimes when we say, we're going to cut this leg off, they look at us as if we are very wicked. Or when we say, this eye must go out, they look at us as something is wrong with this person. You want to remove my child's eye. It's like saying you want to remove my child's heart. But if they come on time and we're able to counsel them and they agree to this, then the chance of cure is very high with childhood cancer when they present to us early. When they present late, usually there's nothing we can do. Thank you very much.
Thank you, all of you, for sharing. We appreciate you all.
Thank you for watching. Please like, share and subscribe for new video updates.